I'm glad to talk about keratopigmentation associated to oculoplastic procedure. I don't know how many oculoplastics are here, but I would like to share my experience because it has totally changed the way I treat patients right now compared to the way I was taught to treat those patients. So I want to ask you, rehabilitation of physical eyes is a challenge. It's a big challenge. We were talking before about psychological impact of these patients. They do not only have cosmetic problems, they have functional problems, they cannot see, and also a psychological problem because of this non-sighted eye. And it's not easy to treat those patients. And we are not going to do the same surgery in every single patient because they have different degrees of physical eyes, okay? So if we look at the patient on the left, we see an eye with volume, and we see the patient of the right, we see an eye without any type of volume. So are you going to treat both with prosthesis, implants? I think no. I think the answer is no. And we all know the conventional treatment, prosthesis and implants. And normally when these patients come to the clinic, we said to them, or I used to hear in the hospital where I was trained, that don't worry, we are going to remove your eye and you're going to stop having pain. And that's not true, because if you look at the complications of implants and prosthesis that I'm going to show you, it's important to take that in consideration. And also the stages of physical eyes is not the same if we see only atrophy without shrinkage of the eye than when we see atrophy with a shrinkage eye. So it's not the same way we are going to treat all of them. We have to think about the stage of the phthisis and decide the treatment depending on that. And if we go back to those two cases, we do a different rehabilitation for those physical eyes, completely different. We treat the left patient with our keratopigmentation technique, doing a decompression to reduce the ophthalmos, the exophthalmos, doing an squint surgery and rehabilitating that eye. And in the patient on the right, we did a completely different. She already had a prosthesis that was extruded, and we had to put an implant and repair the ptosis. So it's different, the treatment we are going to do in each case. We have to think that when prostheses work well, we have to use them, because when volume is necessary, we have to look for symmetry, we have to look for cosmetics, we have to look for long-term success, but we have to know that prostheses are always worse in extraocular motility. They will never look the same. The eye in a picture looks very nice, but when they are living and they move the eye, the prosthesis won't move the same way an eye moves. So we have to think that the patients are not pictures. The patients are patients and they move the eye. So talking about complications, we have many complications using implants. We have extrusion of an implant. This patient came with the implant in her hand. We have post-nucleus Stockholm syndrome that is very obvious in these three cases. We can have ectropion due to the heavy prosthesis pulling the lid back down that might require graft to hold the lid up, like in this case. We have also ptosis because of the levator muscle rubbing the prosthesis all the time. We can have shallow forniceps. Sometimes the patients blink very hard and the prosthesis simply are out because they don't have a pocket where the prosthesis can stay. So that shallow fornix can also be treated. We can have granulomas, we can have socket contracture. So it's not true that the prostheses are going to fix the problem of the patient. And also we have difficulties. For example, this kid has a prosthesis on her right eye. Imagine her mother removing and putting the prosthesis every month to clean it. So it's important to have an additional technique to treat all these cases. And what if we would treat instead of cover the problem? And that's the issue. How can we treat? To treat is more difficult for sure, but we are ophthalmologists and we can treat those patients. We have to think about 5 things when we treat an eye and not cover. We have to think about orbital volume, about corneal opacity, where it is, deep, superficial. We have to think about the strabismus. We have to think about the lid position, ptosis, ectropion especially, and the IOP. Pain. If they are on pain because of higher IOP, we have to treat it, okay? And although not all the patients require the full treatment, we sometimes do orbital treatment, sometimes do corneal opacitive treatment, sometimes extrabismus, and combination of treatment is what is going to give us a success. For example, this patient only received, we treated the enophthalmos and we treated the corneal opacity with keratopigmentation. In this case, we did opacity and strabismus surgery. In this case, we did opacity with keratopigmentation and lid position ptosis correction. And we think about those 5 steps, and regarding, as an oculoplastic ophthalmologist, I think that we have to think 2 problems. We can have the eye sunken or the eye exophthalmic. In both cases, we can treat them. We can give volume, putting fillers inside the orbit with the retrobulbar and the peribulbar cannulas. We can put the normal fillers that people use to look good, to put in the orbit and restore the volume of those cases. And also we can treat the exophthalmos doing decompressions to push the eye in, removing some walls, and improve the cosmetic of the eye. In this case, we are having a patient with a prosthesis, and this is the outcome after ptosis repair and fillers inside the socket, volume augmentation of the socket. I think the outcome is quite good, and we have to think about volume all the time in these cases. Or this case, he has ectropion on his left eye and a sunken eye and a sunken prosthesis, and after restoring this, it looks much better. You can see the difference when we give volume to the orbit. We can put fillers inside and restore the appearance of the eye. But when we have the opposite, when we have an exophthalmic eye, we can also give a better outcome by doing decompression of the eye that is more exophthalmic. Obviously, it's not going to be perfect. This is an unsighted eye, but it gives a better outcome to that patient, not having to remove that eye. Especially in kids, we have to think about preserving the eye, and sometimes decompression can give a good outcome to them. So we have to combine technique. We have to combine keratopigmentation with strabismus, with ptosis, with cyclodiode to control pressure, with fillers, with decompression, and obviously this is much more difficult than doing an evisceration and putting a prosthesis on. For example, in this case, we have performed cyclodiode to reduce the pressure that was so high. It was around more than 60 of pressure, that he had this ophthalmos due to the high pressure he had. This ophthalmos was much better after we treated the intraocular pressure and did the keratopigmentation. This is a previous case after decompression of the right eye, ptosis repair, strabismus repair, and keratopigmentation of the right eye. This is a case after filler injection in the orbit and keratopigmentation of the right eye. This is another case. For example, we can use also this treatment to treat aniridia. As we said before, traumatical aniridia can also be treated this way, and it gives us a very good outcome. In this case, we not only achieve a good outcome cosmetically, but the patient improved vision for count fingers to 60–70%, because vision was much better after keratopigmentation, and for aniridia cases is a very good technique. This is also a traumatic aniridia. In a case, the right eye was keratopigmented, and the outcome is really good. We have several papers talking about the corneal tolerance, the tolerance not only histopathologically, but also an immunological tolerance of the cornea to these pigments, and how safe is this technique, to consider it to avoid more mutilating procedures. And I'm going to bring you, just to finish this case of a pediatric case, a kid, where an evisceration was recommended, and how can we avoid, in a kid with no vision on his right eye, this mutilating procedure, and how he looks on the left, very natural, and the impact, the psychological impact he can have after keratopigmentation. I'm going to show you the surgery of this boy, so you can see the technique, the normal technique that I learned from Dr. Alliot, and I'm very glad that he told me this technique, because now my oculoplastic patients are not suffering with eviscerations all the time. We are trying to restore the eyes, is what we should do. Here you see how we create the tunnels, the way we have seen before. And we have to take in consideration that we were dealing with tisical eyes. Sometimes laser cannot cut as good as in a normal cornea, and we have to do very superficial tunnels sometimes to cover the defect. If the scar, or in this case a deposit, is very superficial, we have to consider doing the tunnel where we have to do it to try to deal with the opacity. And here we mix the colors. We try to make the iris the more natural we can. Obviously, we are treating with different browns to try to mimic an iris, a normal iris. And then we create the pupil area. And I think that no pupil would be better than a laser pupil. I have done keratopigmentation superficially, and it's never as beautiful as a pupil done by a laser. And a pupil is very important. I think it's the most important thing to have a good outcome. If the color is not that good, but the pupil is good, the outcome is perfect. Because pupil gives the center of the eye, I think is the most important thing. You can have different iris color, but if you have a pupil, the eye looks natural. So to conclude, what would you choose? Prosthesis or keratopigmentation?
Keratopigmentation.
Raise your hand. Obviously, we don't have volume. Evisceration implant can play a role, but if we have an adequate volume, treat and not cover the eye. That's my advice. And keratopigmentation is part of an oculoplastic rehabilitation, and we have to think about treating and not covering the eye. Thank you.